Hello viewers, this is Smriti Patel presenting a highlight video on Dandy-Walker syndrome by Smriti Patel and Francesco Mangano from the University of Cincinnati College of Medicine and Cincinnati Children's Hospital Medical Center. At the end of this video presentation, viewers should be able to define the diagnosis of Dandy-Walker malformation and its relationship to a spectrum of related disorders. This presentation aims to describe the basic clinicopathologic and diagnostic features of Dandy-Walker syndrome. Dandy-Walker malformation is a well-known malformation that has been associated with other central nervous system and other systemic anomalies, including genetic aberrations, environmental factors, teratogens, and congenital infections. The goal of this talk is also to provide an explanation of the treatment controversies that persist today and a suggested treatment algorithm for the current management of hydrocephalus in the setting of Dandy-Walker syndrome. It's important to note that this disease process does not occur in isolation and may be related to other comorbid conditions. Dandy-Walker syndrome represents the collection of clinical manifestations of a congenital malformation largely characterized by agenesis or hypoplasia of the cerebellar vermis, cystic dilatation of the fourth ventricle, and enlargement of the posterior fossa with or without the development of hydrocephalus. It has been reported to occur in 1 of 25,000 to 30,000 newborns, with the majority of patients presenting within the first year of life. In those patients that develop hydrocephalus, it is done so by the age of 3 months. Occasionally, in less severe cases, diagnosis may be delayed until adolescence or even adulthood. Concurrent hydrocephalus may not be present on prenatal imaging or at birth, but has been reported to occur in roughly 80% of all patients with Dandy-Walker syndrome. The most common postnatal presentation is macrocrania. Other signs and symptoms in this age group include the sunset sign, a large posterior fossa, seizures, spasticity, lethargy, delayed milestones, respiratory failure, apnea, deafness, visual problems, or other signs of increased intracranial pressure. The incidence of associated anomalies in the central nervous system is variable, but has been reported to be as high as 68%, with systemic abnormalities present in about 1/4 of patients. The most commonly associated central nervous system abnormality is agenesis of the corpus callosum. Dandy-Walker syndrome corresponds to a spectrum or a continuum of posterior fossa cystic malformations, which we discuss in the following slides. Historically, the only imaging characteristic consistent with Dandy-Walker syndrome has been an elevated torcular hierophyly visible on plain radiograph, known as Busey's sign. Currently, diagnosis of Dandy-Walker syndrome is made on the basis of anatomic findings that may be identified on fetal or postnatal ultrasonography or MRI, as well as CT. However, MRI represents the gold standard test. CSF dynamics are increasingly being utilized with flow studies and Cine MRI sequences, which can often determine the etiology of hydrocephalus if present. Fetal MRI, in particular, has been used as a helpful adjunct in diagnosing this condition prenatally, given the potential for associated congenital abnormalities and the high incidence of cognitive and developmental delays, but it is insufficient for anatomic analysis of the vermis. The first disorder we will discuss is Dandy-Walker malformation. Dandy-Walker malformation requires 6 key diagnostic radiographic features. 1. A large posterior fossa cyst communicating with the fourth ventricle. 2. Absence of a portion of the inferior vermis. 3. Hypoplasia, anterior rotation, and upward displacement of the remaining vermis. 4. Absence or flattening of the angle of the fastigium. 5. Large posterior fossa with torcular elevation. And 6. Anterolateral displacement of the cerebellar hemispheres. This is in contrast to Dandy-Walker variant, first introduced as an entity by Harwood, Nash, and Fitz to describe a milder form of Dandy-Walker syndrome-like signs that were not congruent with the classic definition of a true Dandy-Walker malformation. Dandy-Walker variant consists of a communication between a normal-sized cisterna magna and fourth ventricle, as indicated here by the white arrow, absence of the inferior vermis, and absence of the corpus callosum, which is seen here indicated by the black arrow. Another term coined to describe a continuum of posterior fossa anomalies is Dandy-Walker complex. It is categorized from mild to severe. The mildest form is otherwise known as megacisterna magna. In this slide, on the right, is a mid-sagittal T1 weighted MRI, which demonstrates a megacisterna magna. Megacisterna magna is a normal variant characterized by a truly focal enlargement of the subarachnoid space in the inferior and posterior portions of the posterior cranial fossa. The moderate form is defined by mild hypoplasia of the vermis with an enlarged fourth ventricle, demonstrated in this mid-sagittal T1 weighted MRI. The severe form is defined by agenesis of the vermis, dilation of the posterior fossa cyst and fourth ventricle with associated hydrocephalus, depicted here in this mid-sagittal T1 weighted MRI. Dandy-Walker syndrome must be differentiated from other related disorders or malformations of the cerebellum, such as a persistent Blake's pouch cyst. Blake's pouch cyst is a rare entity and is defined by a cystic appearing structure or arachnoid pouch that represents posterior ballooning of the inferior medullary velum into the cisterna magna, below and posterior to the vermis. It communicates with an open fourth ventricle. A Blake's pouch cyst occurs due to the failure of regression of Blake's pouch, secondary to the non-perforation of the foramen of Magendie. This disorder may present in a variable clinical fashion. Seen here on the right is a mid-sagittal T1 weighted MRI, which demonstrates a fourth ventricle that is contiguous, as shown by the white arrow, with an arachnoid pouch below the cerebellum, indicated by the star. There is some upward mass effect from the pouch. However, there is no vermian hypoplasia or rotation noted. Treatment options for Dandy-Walker syndrome currently consist of cyst membrane excision, CSF diversion with shunting, endoscopic third ventriculostomy with or without choroid plexus cauterization, and aqueductal stenting or shunting. Although early series of cyst membrane excision reported good outcomes, its poor efficacy was demonstrated in multiple follow-up series, with up to 75% of patients still requiring a shunt and mortality approaching 10%. Currently, this is a largely abandoned initial procedure for treatment. Diversion of CSF with shunting is currently the most widely accepted first-line treatment for Dandy-Walker syndrome. However, significant controversy exists in terms of which type of shunting procedure yields the best results. Options include shunting the supratentorial compartment, shunting the cerebellar cyst, or shunting both compartments with what we describe as the dual shunt. Other alternative treatment strategies that have been described include endoscopic third ventriculostomy, or ETV, with or without choroid plexus cauterization, or CPC, and aqueductal stenting, or shunting. From the current retrospective evidence, it would be difficult to establish a universal treatment algorithm for Dandy-Walker syndrome. Based on our review of the literature and current trends, we have provided a proposed treatment algorithm. Let's first start by focusing on the left side of this algorithm. Once imaging is obtained, which confirms Dandy-Walker syndrome and hydrocephalus, a Cine MRI is recommended to assess for aqueductal flow. If the patient has aqueductal stenosis on these imaging studies, and the patient is younger than 1 year of age, it is recommended for the patient to undergo a dual shunt. If the patient is not younger than 1 year of age, and the MRI shows favorable anatomy, one can consider an ETV with CPC with or without aqueductal stenting. If the anatomy is not favorable for a third ventriculostomy, then we recommend a dual shunt. Now let's move to the right side of this algorithm. If there is imaging confirming Dandy-Walker syndrome with hydrocephalus, and the Cine MRI, which assesses for aqueductal flow, does not show aqueductal stenosis, and the patient is younger than 1 year of age, we would recommend either a cyst to peritoneal shunt or a supratentorial ventriculoperitoneal shunt alone. If this treatment strategy fails, we would recommend a dual shunt. If the patient is not younger than 1 year of age, then we would recommend reviewing the MRI to see if the patient has favorable anatomy for being considered for an ETV with CPC. If this strategy is chosen and the strategy fails, we would recommend a cyst to peritoneal shunt or a supratentorial ventriculoperitoneal shunt alone. If this treatment strategy then fails, we would recommend a dual shunt. If the patient does not have favorable anatomy on imaging studies, we would recommend a cyst to peritoneal shunt or a supratentorial ventriculoperitoneal shunt alone. If this initial treatment strategy fails in these patients, we would recommend, ultimately, then a dual shunt. In this chapter and this video, we describe a dual shunt system, which involves shunting the supratentorial and infratentorial compartments. Starting from the left, here we show a CT of the head without contrast, demonstrating the infratentorial catheter terminating in the posterior fossa cyst. Here in the middle, we show an axial cut, which shows the supratentorial catheter terminating at the foramen of Monro. On the right, we show a lateral X-ray that demonstrates the supratentorial and infratentorial catheters, which are connected using a T-connector, which is then connected to the distal valve and tubing system. The prognosis of Dandy-Walker syndrome is highly variable due to the spectrum of severity and variety of associated conditions. Mortality rates have improved significantly over time due to advances in medical and surgical care, as well as improved management of hydrocephalus. In children treated successfully for hydrocephalus, prognosis mainly depends upon the comorbidities. These include presence of seizures, hearing or visual problems, and other organ system or central nervous system abnormalities associated with poor outcome. In summary, Dandy-Walker syndrome is a rare disorder that may be accompanied by multiple congenital central nervous system and other systemic anomalies. Hydrocephalus associated with Dandy-Walker syndrome is a major neurosurgical concern. Treatment may consist of CSF diversion of the cyst, ventricular system, or both. Prognosis for patients with Dandy-Walker syndrome with or without hydrocephalus is typically dependent on other comorbid conditions. The authors would like to thank you for your attention and interest in this topic. We hope that we have provided an informative overview of Dandy-Walker syndrome.